I do pediatric sports medicine. My background is both in, I did my residency in orthopedics and subsequently did fellowship both in pediatrics and in sports medicine. And that's my particular interest. And then I also do hip arthroscopy as well. My wife frequently asks me to help out with our children and look in their ears, and I keep on reminding her that I'm not a real doctor. And so last night when I'm putting the presentation, I'm putting some last minute touches to it. She asked me what I'm doing, and I said, well, I'm giving a presentation to pediatricians. She goes, oh, you're talking to real doctors. And I said, yes, exactly. So I appreciate you guys having me here. This is a presentation that I really enjoy giving. I have no disclosures, but really what my goal here is for you guys just to sit back and relax and you guys, we get a lot of presentations, but this one is really for me to try to communicate to you the things, to try to catch that line, that missed line in the grass, and that especially with hip pathology that in kids can sometimes be a little bit scary, or since an orthopedic surgeon, I think this is a really important, some of these are really important topics. So I'm going to just focus on some of the areas that I think would be important for you guys to look into, and I'm sure you've seen a lot of this pathology, but that line in the grass, can frequently come my way, and all these images are representative of the pathology. So if you see a picture of a dancer, that's because that pathology goes with the dancer. And all of these x-rays are really patients that we've seen in the last year that have been sent my way for various reasons. And these are what I call lines in the grass. So really what I'm going to focus on is, the atraumatic hip pain in the athlete that has continued hip pain. I'm talking about, we used to say athletes are just at the high school level, but nowadays athletes really start at age, 5, 6, 7, 8-year-olds are in highly competitive athletes now. So we're talking a lot of this pathology here that is presenting as atraumatic hip pain in the athlete, and kind of what's important and where are we going from here. And the things that I call the lines in the grass are these things here. So these are the ones that I pay particularly attention to, and these are usually my first 30 seconds of my exam. I want to make sure it's not one of these, and then I can move on to figure out something else. At least in my world, this is a hot topic. Hips, we're seeing hip problems in young athletes more and more. It's hot topics in our journal and in many, many journals, and I presume it's probably pretty important in your all's neck of the woods, and there's probably good reason for this. We all know that there's different distribution curves when it comes to growing in a child, and there is an adolescent growth when they hit their growth spurt. But there's more to it than that. It's not just a growth spurt, but this is a femoral torsion curve that's presented here. And so not only do you have two peaks of growth that we know of in pediatrics, but there's also rotational differences that's coming into play as well. So you've all had those in-toings in your clinic that you say, oh, that'll get better, and then they come back when they're 6, 7, 8 years old, and they're not any better, and they say, well, they're still in-toeing or they're still out-toeing. Well, there's still even some change that occurs even in adolescence when they hit their growth spurt. And this is probably a reason why we're seeing a lot of hip pain and hip problems in this age group, especially during that 8 to 14 year, 15 year, because there's a lot going on in these kids. Not only is there a lot going on because of their growth plates, because there's a lot of those around the hip, kind of like the elbow, but also these this concept of apophysis, and I think only pediatricians and pediatric orthopods really have a good familiarity with apophysis, but the extra areas of cartilage that frequently are very weak and cause a lot of inflammation. And I bet everyone in this room has been struggling with Osgood-Schlatter's in their clinic at one point in their career. But you know what? This happens a lot around the hip, and this is a very frequent area of overuse injuries, a very frequent area of apophysitis, and we're seeing it more and more, much more than we really did in the knee. This is just a little bit of an overview. That was a bit of an introduction, but a bit of overview what I'm going to talk about. I'm going to try to really focus on the diagnosis and my philosophy on radiologic imaging and window order. You guys got a great talk. I just actually flipped through it in the back. That's coming on next, so I will try not to go too much into the radiology of the hip, but really focus a little bit more on things that would be important for you guys. I have this slide for every talk I give. It's kind of it's pretty much a blanket statement that I'm sure you guys have seen before. I just think it'd be malpractice if I did mention it at least once today. But obviously knee pain is a hip problem until proven otherwise in my eyes. Now, this doesn't mean that I get an x-ray of the pelvis every single time, but this means every time I examine the knee, I examine the hip, and that takes about 2 seconds for me to flex up the hip and rotate it and get a feel for how this hip feels compared to the other hip. I do frequently get x-rays of the pelvis, but I don't on every single kid that comes my way is my point. A little bit of background about the hip. And I apologize if this is a little too elementary, but I don't want to use terminology that we're not all familiar with. But the femur comes up to the pelvis here, and the hip joint is a ball and socket joint. It's very much a true ball and socket joint with a lot of congruity in the bone. And so there is some soft tissue stabilization around the hip, but not as much as other joints. And so the bony congruity is very, very important. I call this the head of the femur, and then the socket is the acetabulum. The labrum, which is become much more of an important topic these days, is a thin cartilaginous rim that surrounds the pelvis, and it does a lot. It gives you stability, it gives you extra depth of the socket. It also decreases the amount of contact pressure that the hip joint has. So without a labrum, there's a thought that you can have worsening arthritis because of increased contact stress on the cartilage. So that's probably the main kind of anatomical, probably the most important part of the hip, but it's still complex. Lots of muscles, lots of structures, lots of muscles, and all these can be hip strains that can frequently happen. Still, about 75% of my practice is an acute football injury in which I have a hip flexor strain or a hip strain. That is still the most common thing that we see. All this other stuff is the stuff we don't want to miss. The history is, not anything's different from any other joint in the body. Particularly what's important in my eyes is, pain is very important, but really mechanical symptoms, that popping, locking, catching sensation, instability. Family history is really important for DDH in our eyes. Infection, tumor, this is pretty much your all's bread and butter. And then obviously, kind of that remote trauma sometimes can be a hint into an acute on chronic skiffy. When I first started orthopedics, I really thought that the hip was very difficult to examine because I could only really do one thing, or two things, and that's flex it up and internally and externally rotate it. Because the knee was so much easier. I can move the kneecap around and check the ligaments side to side, the shoulder, it's much more greater arc of motion and degrees of freedom. But turns out that the hip also can be really predictable, very similar to Osgood-Schlatter. And so kind of, the inspection, palpation. The knee, I can do most of my knee exams standing up and laying supine. In the hip, it's impossible. You got to get them standing up. I get them laying down. I lie them on their side, and I lie them supine, then on their side, and then on prone, because that's the only way I can really examine the entire hip effectively. Standing up is really important. I'd say in the last 3 months, I've referred a scoliosis patient with hip pain that comes to my clinic to my partners. I always take a look at their back, their alignment of their pelvis. Leg length discrepancy seems to be something that families have a lot of stock in, which may or may not truly be clinically important, because I think just about everyone has about a 1 centimeter leg length discrepancy, but certainly that can be helpful if you see a large discrepancy in their pelvic alignment and their pelvic obliquity just when you're staring at them from the back, when you're looking at any evidence of scoliosis, and that can mean several other things. Whenever I examine someone with the hip, I always touch the back. I touch the SI joint. We've seen sacroiliitis that it gets referred to the rheumatologist that was presented as hip pain. So this is a really important part of the physical exam. Palpation of the hip, this is what I was alluding to earlier. Osgood-Schlatter, you walk in the room and you can kind of see Osgood-Schlatter, and it doesn't take the kid, 20 seconds just to kind of point right there that it's an Osgood-Schlatter and we know what the treatment is. The hip can really be the same way. You point right over that greater troch on the outside of the hip, and you know that they have some bursitis or tendonitis, and it's very predictable. You can do the same thing with the ASIS, that prominence in the front part of your hip here, and there is an apophysis there, and it is very painful in sprinters and runners and football players in soccer, and that is very predictable as well, like we talked about before, the SI joint. And then the pubic symphysis. The only thing I really say about the pubic symphysis is I always do my hip exams with the chaperone in the room, and I would just, you guys are well familiar with examining sensitive areas, but in orthopedics we typically do not. But this is one of them, so I just make mention of that, especially when you're doing the exam. Range of motion is really important. Not important to really memorize these numbers. I would stress more to do contralateral image. You always examine the contralateral side, especially if you're looking for something like Skiffes or Perthes, idiopathic chondrolysis. Anything in which you have a substantial decrease in the range of motion is very important. And these are averages, and averages are not as important to me as what the other side feels like as well. So I would really encourage that to be something that's part of your physical exam repertoire. Kind of some special tests that we look for that help me look at a few things, and you guys will notice I'll try to spend a little bit of the talk on things that may be pertinent or try to be helpful in your all's clinical exam, but also just to educate you on some up and coming diagnoses in the hips that are becoming much more prevalent. And one of them is impingement and a labral tear. And this test where you flex up the hip and you cross their body, adduct hip, and you internally rotate it, is very reproducible for a kid that has anterior impingement in their hip. I don't really get a lot of pain here with the hip flexor strain. I don't get a lot of pain here with Perthes. A kid with Skiffes can't internally rotate his hip. So to me, this is a very valuable exam when I'm examining a child or when I'm examining anybody. So then talking about that line in the grass, what do we do and when we order labs? This is, we see a lot of pediatric infection at Children's Hospital, pediatric musculoskeletal infection. One of my partners, Lawson Copley, has dedicated his entire career to musculoskeletal infections, and so he's developed very long and complex protocols for our musculoskeletal infections that get presented at Children's, but generally speaking, we do not hesitate on getting labs with any new onset limper that has any funny history associated with it, especially in the younger child. Our routine, our protocol is very simple: a CBC with a diff, ESR, and CRP. It would not be, I don't want to spend too much time on this aspect because you guys are probably well familiar with it, but it would not be uncommon for a couple times a year for us to catch up on a leukemia patient that was a referral due to a refusal to bear weight consult or a limper or a hip pain consult, so we do frequently see it. The KOCHER criteria is, don't know how familiar you guys are with this, but this is something that we are very familiar with in the orthopedic literature in terms of the criteria of trying to determine if someone has a septic hip or not, or a septic arthropathy. The criteria were non-weight bearing and ESR greater than 40, febrile, or a WBC of greater than 12,000. Now, we use CRP nowadays a lot more than we do ESR because it's just a little bit easier for us to follow the trends acutely. And this criteria was really helpful because it started getting us to think a little bit more about what the prevalence is of septic arthritis in a presenting hip patient to us. Now, this was done as a retrospective review. Prospective reviews have not really found that these numbers are exactly accurate, but here's the deal: when I'm trying to figure out what to do with a family and I'm talking to a family, I can quote numbers to the family that make it easier for me to communicate decision making. And I always do a combined decision making, so I can tell a family, you really only have 2 or 4 KOCHER criteria, a 40% chance of a septic hip, therefore, because of X, Y, and Z, I would recommend this. And, sometimes you have families that don't want to be aggressive or want to be more aggressive. Or if I only have 3 or 4, I can say, hey, here's the deal. I know they're not febrile, but they got a 93% chance based on what you're telling me, based on what I'm finding, that they're going to have a septic arthritis and we need to do something about it. And so to me, this is very, very helpful, in terms of counseling and educating family members. Imaging, a variety of imaging we use for the hip. Sometimes it depends on the age, the pathology, what we do. Plain radiographs are the mainstay of my recommendations. When it comes to the hip, I recommend an AP frog leg of the pelvis, no matter what. So hip joint, I don't care if it's left, right hip, AP frog leg of the pelvis is very important. This gives us our AP and our lateral of the hip joint. And you can see here, this actually was this was a patient in which they presented to me with x-rays of the hip, and I actually originally thought that this was part of that triradiate cartilage that you see that closes around the age of 12 to 13. an extra growth plate. And then when I got the AP pelvis, I thought, this is not usually asymmetrical. There are some growth plates that are typically asymmetrical, but this one is not one of them. And so, the AP pelvis, and subsequently was worried about it. There's something strange. Went ahead and got an MRI, and lo and behold, it was a stress fracture right here that is very similar to a very unstable pelvic fracture called a transverse acetabular fracture. So she actually healed this quite well with conservative measures. Examples of the differences between an AP and a frog leg and what are the true importance. This is an AP of the pelvis. So we have, pelvis, the pelvic ring here, hip joint here. I could probably say from the back side of the room, I could look at this at a glance, say, something doesn't look right. I don't know what it is. Someone who doesn't look at these all the time, I'm sure, doesn't look too abnormal. But when you get that lateral, you see that ice cream cone has fallen off that head, and we would have never seen it otherwise. And so the AP frog leg, especially when you have a patient presenting with a potential slip capital femoral epiphysis, this view is extremely important because, as you can see, here's that growth plate here, here's the epiphysis, but that ice cream cone is, I always call it the ice cream cone, but the ice cream is falling off the cone. You can see it here. We can see lots on x-rays. Sometimes we just say we can only see the bones because family ask us what else we can see here, but we can certainly see a lot of things on the x-rays that help us. Ultrasound, it used to be in a huge favor. Now it kind of came out of favor. Now it's back in favor. We could look for hip effusions, probably the most common reason that we use this at Children's globally. I do injections into the hip, especially for the little bit of the older athletes, because sometimes I can't figure out what's going on with the hip. So I do diagnostic injections that can be both therapeutic and diagnostic as well. Here's just an example of an ultrasound. You guys have seen all of these in your office, comparing one side to the other side to look at a hip effusion. Can help us figure out if we need to drain that or not. All of this is in your all's handout, so I didn't. All of the slides I added between now and then are all pictures, so most of the content is the same. So please don't feel like you're going to miss anything that's written up here. Here are the indications for an MRI of the hip, at least in my eyes. The only thing that I would stress is if you think someone has impingement based on what you have heard from me today or from what you've heard in the past, I would either hold off on it or be sure that you order an MR arthrogram. I've had to reorder a lot of imaging MRIs of the hip based on the assumption that I think that they have labral pathology, and you just can't see it with a traditional MRI. So that's just reiterating that point here. An MRI sequence of the hip joint in which the fluid is bright. You can see the hip capsule down here. You can see it's a nice bony congruent joint here. Here's the other edge of the capsule. That labrum is supposed to be a nice thin rim, and the advantage of getting the contrast in there is the contrast sneaks up in this area here, and you can see how that labrum is pulling away from the cartilage, indicating a labral tear. And that's really the biggest difference on a traditional MRI versus an MR arthrogram. So this is, in kind of a 40-minute talk, sometimes I do so much talking that I just kind of have to take a little bit of a breather and a step back and consider this my commercial. Injury prevention, I like to talk about it at least once every talk I give, and the reason being is these kids are getting hurt more and more often, and that's my job security, but also why I'm here is because I want to prevent these injuries, and I spend a lot of time learning about injury prevention mechanisms, do research, injury surveillance protocols. We have handouts that are on our website as well talking about injury prevention. We know that there's certain bone morphologies like this impingement that we always thought used to be in hockey players. You hear me talk about that a lot because that's a lot of my referrals right now. But we know that the young active kid between the ages of 12 and 14 are involving this extra bone lesion on their femoral head, and that has been a problem because the incidence of this impingement is climbing and climbing and climbing. And there is some evidence based on some work from Siebenrock that has demonstrated that the young, active, healthy kid is really the cause of some of this bone morphology. So it's really interesting. For me, I have a philosophy about why this is happening that is a personal philosophy. There's been no real literature. A bunch of experts have given their own philosophies, but I think kids are playing too hard, too young, and they've committing themselves to a single sport because of the pressures of their coaches or schooling and everything else. So I highly recommend variability in my athletes. Try not to commit them to one sport year round. I think variation in their exercise and the workout routines. And if they are that serious athlete that tells me at the age of 9 that they're going to be the next Peyton Manning, which happens, I at least strongly recommend to their parents that their body is not ready for them to play at a level of a skeletally mature athlete this young. And both Tom Brady and Drew Brees have vocally said that they did not play football till their age of 14, and you hear me say that a lot because parents are surprised about that statistic. So now I'm going to get into some pathology, and I will, all the stuff's in your handout, and I don't want to bore you guys by just listing diagnoses, but try to point out some interesting stuff that would be helpful in your clinical setting. The first one is snapping hip. This can sometimes be very scary, and she actually said my hip comes in and out of the socket. It keeps on dislocating, and I thought, surely not, and when the nurse told me, I skipped my next 3 patients to go directly into her room because I thought I can't have a girl whose hip is dislocating in my clinic right now. So I had to jump in her room, and this is her. She is also a young athlete, a volleyball player, and this is her snapping hip. Snapping hip is also called COXA SULTANS. It's kind of the fancy doctor term for it. We call this internal or external depending on the location of it, but it can also be intra-articular. So it can also be a loose body from Perthes. It can be an OCD of the hip. It can be a labral tear or impingement as well. Commonly, though, a snapping hip is either internal and external. I'll tell you the differences, right now. Internal snapping hip is from the iliopsoas, which is one of your hip flexors. And this is the one where they say, my hip pops. Yes, it sometimes hurts, sometimes it doesn't. And then mom will say, well, I can hear it pop. And this is one that they can make it kind of go pop. And they do the motion in which they come from that Faber position. They roll their hip around and they can make it pop. And it's frequently audible. This is in your dancers, your cheerleaders, your gymnasts. Again, this is just some additional information. The beauty of this particular problem is it's almost always treated with physical therapy and reassurance. This is stretching of the hip flexor. I recommend doing this particular stretch. It's called a Thomas stretch, where they hang their leg off of the bed and they allow some stretching of their hip flexors. There's other ways to do this. It's really good in some Pilates or yoga exercises to flex your hip flexors. Now, when you try to tell a cheerleader or a gymnast that they need to stretch, they laugh at you. Are you kidding? And they put their leg up and I'm flexible as they get. Not true. They're flexible in some directions, but then they're tight in others. And that's why they compensate in other directions. They end up having a tight iliopsoas, and that's what creates this hip flexor and the snapping hip problem. The one you saw before is called coxa SULTANS externus, or external snapping hip. And this is in the same population, but tend to be the super, super thin ones. Not the ones that have that small gymnast figure, but the ones that are really tall and very thin. And that's because they have the wide hips, and then they subsequently have an IT band. This is my physical exam of the Ober. It was described in 35, and it is a physical exam for the tight IT band. I do this on every single patient. I find that a lot of them are extremely tight, and it is almost always tight in those presenting with a snapping hip. This is, like I was saying before, this is also, the beauty of this is also treated not with a surgery, but this is treated with stretching of that IT band, which is a very thick fascia coming from the top of your iliac crest. It forms that extra muscle on the side of your hip, and then it's a tight band that goes all the way down. The tight IT band is going to be frequently seen in your kids with patellofemoral disease as well. So this is a part of the body that can be very, very tight and can give a lot of symptoms in the hip and in the knee. I occasionally operate on these, but I try my hardest not to because they're almost always treated with really good stretching. I'm going to spend a little bit of time. Hopefully this is a time where you guys can just relax and just learn something new about the hip. But hip impingement, femoral acetabular impingement, or FAI as we frequently call it, is a very common condition to the hip. It's becoming much more popular, and there are some famous athletes that have certainly popularized this particular problem, and that's why we now have a lot of understanding and a lot of research is going into this. But here's the deal: everything we know is in the adults. What we're learning is that this is happening in the kid, and it's not. And this is a kid who is, 14, 15, 16, 17 years old. When I did my fellowship, I did an adult sports fellowship. We mainly saw professional athletes to this caliber. In fact, we saw all of them there, and I would frequently, these hips their cartilage is extremely destroyed, but when I see them in the kid, it's not destroyed, and at least my opinion is I'm having an opportunity to hopefully change the natural history. Now, that's not been proven, but at least that's my opinion. So what causes this hip? You heard me talk about overactivity, but then you have a lot of things. This impingement can happen because of sickle cell. It can happen because of SCFE or Perthes, or there's 1,000 reasons why you have hip impingement. Hip impingement is just a condition in which you have too much bone around the hip. It's pushing up against the labrum, and the labrum tears. There are certain radiographic findings that we look for. One of them is called the alpha angle, which is too much bone on the femoral head. The other one is acetabular version. So we look at the rotation of it, and it's creating too much bone in one direction or another. This condition is treated arthroscopically, so it's not a very big incision. We fix the labrum with screws and anchors, and we shave off all the extra bone, and all of the outcomes seem to be very, very good, at least in the short term. It's a condition in which you have too much bone around the hip. I know you guys don't look at a lot of hip x-rays, so I tried to outline where the extra bone was, and you can see we kind of shape it down to make it look more like a normal hip. I went ahead and took a look at 64 of these adolescent athletes to my mentor, which is Mark Philippon. Many of them did, about a third of them had open physis. None of them had major complications, and all the ones that needed repeat arthroscopies was due to scar tissue, which we changed our protocols for it. Perthes disease, idiopathic osteonecrosis of the femoral head, is a really interesting condition that when I started my practice, I went around and met some pediatricians, and they said, now tell me about Perthes. I keep on hearing about it, but I've never seen it in my practice. And I suppose when you work in pediatric hips, like I do, I see quite a few of these. So I think they're much more prevalent than they probably really are in your all's practice. So it is a condition in which you lose the blood supply to that epiphysis, which is, up here, that extra, ice cream cone when we talked about a SCFE. When you lose blood supply, and then, there's a lot of different ways in which it can present, but you just lose bone, and it becomes fragmented, and it just doesn't look normal, and then their hip gets stiff, and then, do they need surgery, and do they not need surgery? The important parts for this pathology is recognition, early management, and then really giving the family some expectations. And this is usually your smaller kid, small for his age, hyperactive, loves to play sports. This is the mom that says, my kid's in, 5 sports, and Monday, Tuesday, Wednesday, Thursday, Friday, I can't slow him down. That's the kid that gets Perthes. This is the demographic information. Usually it's a young kid, 4 to 12. They can present with stiffness, but more frequently a limp. This is one of those pathologies that sometimes can present as knee pain, and then subsequently it can be referred to your hip. The workup is a standard workup for the hip, AP frog leg. We do not recommend an MRI, at least up front, and the reason being is two of my colleagues do a tremendous amount of research in this pathology, both from a basic science perspective and a clinical, down at Tech Scottish Rite. We have a special MRI sequence in which we look at the actual blood flow to this region, and that helps us try to manage the treatment from a surgical perspective. Dr. Herring, one of my mentors at Scottish Rite, talked a little bit about the classification of Perthes disease. Not that important from your all standpoint, but it's just important to have knowledge of who needs surgery and who doesn't need surgery, and thinking about the family, because really this is a pediatric orthopedic problem, but we don't want to get weary of outdated treatments. And in the realm in which everybody's operating on everything. This is not something that needs an operation most of the time. And what we found out, it's mainly non-operative treatment focusing on motion, bracing, hip arthroscopy. I'm a little biased because I'm a hip arthroscopist. The indications for that are a little bit fuzzy at this point, so I'm not doing it. And surgery is typically reserved just for the older patient. And we know this because of the work we did at Scottish Rite, in which we found out that don't worry about too much of this graph. Just realize that the green is good, and more green outcomes were seen in the ones less than 8 than the ones older than 8. And the only ones that really needed surgery out of 4 different boxes of categories were just 2 boxes. So not everyone needs surgery. This is mostly non-operative management, decreasing activity, and improving range of motion. And that's certainly the majority of my message with Perthes. Here are just a couple of the take-home points regarding the pathology and the disease. Obviously those that get caught or they present early tend to do better. Slip capital femoral epiphysis. I call it a skiffy. I went to New Zealand, spent some time there, and in England they called it a SUFI. I've heard people just refer to it as a slip. All of those are appropriate terminology in my world, but as you can see, he's also going to talk about this in your next lecture as well, but the epiphysis, this portion of the bone here, starts collapsing off the back of the femur. So I tell a family this is like a stress fracture of your hip. The growth plate cannot withstand the pressure that it's receiving in the hip, and it just starts slowly gliding off. This is the typical patient that you see with a skiffy. Not uncommon for me to have a patient like this walk in my office and think skiffy, and get x-rays of the pelvis pretty quickly. The one physical exam finding that you'll notice, you'll periodically see, is their foot tends to be slightly turned out compared to their other side. These is just some demographic information. It tends to happen a little bit earlier in girls than in boys. That has to do with adolescence and puberty. And then obviously if they don't fit any of the criteria, any of the demographic information, I do an endocrine workup or recommend an endocrine workup due to the amount of endocrinopathies that can also be associated with a skiffy. There's 2 different ways that these can present, one of which is like a limper, and one of which is, I think I fractured my hip. Both of them can be equally as important in our eyes. Sometimes the hip pain goes on for 3 or 4 weeks, and next thing you know, you call your orthopedic surgeon and he's admitting him to the hospital because we're trying to prevent it from going to that next stage where it actually completely falls off. And so in our eyes, this is a surgical emergency. I recommend putting them in a wheelchair, strict non-weight bearing. I admit all of mine to the hospital directly and do them as soon as I can. I almost consider it very similar to an open fracture. The reason for that is there's a difference between a stable and an unstable. So if it's stable, outcomes are good. If it's unstable, outcomes are really bad. And so I don't want to convert a stable to an unstable, and that's why we consider it a surgical emergency. The radiographic findings, like we talked about before, it's really important to look at that frog lateral. There are some things you can look at on the AP, but I find it to be much less predictable. Here's my recommended treatment, which I've already echoed to a degree. Treatment is urgent. Mild slips can really be taken care of very, very easily. It's about a 20-minute surgery, a poke hole incision, and a screw in the hip. It's done under live x-ray. Here's kind of the end result here, and they do really well. They're on crutches for a couple weeks, very little complications. Those ones that become unstable are at extremely high risk of avascular necrosis of the hip, upwards of 50 and 60%. These are the families in which you tell them that there is a very high chance that they'll lose the blood supply to their hip. My partners are doing some work on this down at Scottish Rite as well. DDH, this is a baby disease. Why we have an adult x-ray up here if it's a baby disease? And that's because we are seeing it in these adolescent athletes. Some of the mild DDHs that don't get picked up because they're not necessarily fit the demographic breach, hip click protocols that we all have and we all love, but DDH in the adolescent is also occurring here too, and you can see the difference in the asymmetry, and I'm just reinforcing the fact, the importance of looking at one side to the other, because I may look at that left side and think it's pretty normal off the beat. This is the ratio, but this actually includes all of our baby hips as well, but even when they're older, these are some of the criteria that we see. I, as a hip surgeon, frequently wonder, how do I tell if this is impingement or a unstable hip? and a poorly done study, but the only thing I have to go on is hip flexion and internal rotation is impingement if it recreates pain. If you do the Faber and it has more pain, that may be a sign of more instability or DDH over impingement. Hip dysplasia, although you still have hip dysplasia, you can still have a labral tear, you can still have articular damage. About 2/3 of patients who present with painful hip dysplasia can still have some underlying pathology as well. So we only treat this if it's symptomatic, anywhere from a mild arthroscopy to a big pelvic reconstruction. We focus a lot of attention on that labrum because it's very, very important for multiple reasons, but hip dysplasia also can be treated with a pelvic osteotomy to fix the underlying dysplasia. I currently looked into this study too, presented at the Academy this year, looking at the 45 that we did pelvic osteotomies on, how many of them returned to a very high level of sports, and we're talking 45% of them still return to an extremely high level of sports. So just because they have this and they get a pelvic surgery does not mean that their career is over. Stress fracture is it's a real deal. I showed you a picture of the stress fracture of the pelvis. It was a big deal. This is something that I really I rely on you guys for, especially when I see a stress fracture, to look at the female triad. Some of these females are working out a little bit too hard. Their menses become extremely irregular and their bone becomes significantly osteopenic. They need a lot of counseling, and a lot of times they don't really want to listen to me because I'm just the dumb bone doctor. So what do I know about this stuff? So I frequently will give you guys a call up myself and just talk a little bit about some counseling measures and other things we can do to try to optimize, especially in the face of a stress fracture in this population. So in summary, please don't forget to look at the hip when you're thinking about knee or when they're complaining about knee. Really watch out for infections and tumors. They certainly happen a lot around the hip. That's pretty standard with all musculoskeletal problems. 2 views of the pelvis, any joint in the body is recommended. If you really think someone has a labral tear and for some reason my front desk says it's 3 months to get into my clinic and their family wants an MRI, but you think it's impingement labral tear, be sure you put the contrast in there as well. And then most atraumatic hip conditions are treated without surgery. These are not surgical conditions, most of them, so certainly be wary of that. And then my fear is a SCFE, and so please always think of a SCFE or a slip capitofemoral epiphysis. Thanks, guys.